Hey everyone, this is the osteopathic intensivist. How's everything going today? How's everyone doing today? I am an internal medicine trained critical care physician. I am also a point of care ultrasound enthusiast. So here I'm going to be kind of going over this cardiac ultrasound. I use it extensively in my practice. In fact, I use it as an extension of my physical exam, and it has really made a big difference. As you can see from the indicator, it's a butterfly. I got it this year. It's the IQ Plus. I am very happy with it. And I'm going to be doing some more videos on the features that I see as I'm playing with it. But as you can see, this is a cardiac ultrasound, probably a it could be a subxiphoid view. It could also be a parasternal view. But let's go over what we see here. So first, you can see, let's identify some landmarks. So let's go back there. I'm going to push pause for a minute. See if I can get back there. Okay, so a few landmarks. Okay, that seems pretty good. All right, so this is the right ventricle. This large thing is the right atrium. This is the left ventricle. This is the pericardium. And this is the descending aorta. So it's very important to know your anatomy and know your landmarks. And so obviously this is the tricuspid valve. Oh, let's go back for a moment. That being the mitral valve. And that's a two-chamber view. So two-chamber view, right ventricle, left ventricle. And this is the kind of the view I want to review with you. You see, this is what we call D'ing of the left ventricle. You can really make the outline of the D right here. What happens is the right ventricle is seeing an incredible amount of pressure from the pulmonary artery, and as a result, the lungs and the pulmonary vasculature, that the back pressure is causing the septum to push into the left ventricle. You can really see that. And the cause of that is generally obviously over time, because if this was an acute process that much, the chances that you would have a right ventricular free wall rupture is pretty high. But you can have a PE. It could be a submassive pulmonary embolism, where all of a sudden we're seeing these pressures. The right ventricle is not hypertrophied. There was probably not a significant amount of time for the heart to adjust to these pressures, which is probably an acute or an acute on chronic process. If you have an acute on chronic process in such patients, you're looking at CTEPH, or chronic thromboembolic pulmonary hypertension. So in these patients, it's not necessarily that you have a large pulmonary embolism, but you have multiple small pulmonary emboli, and the sum of all those back pressures goes back to the right ventricle. Another thing that can cause such high pulmonary artery pressures that is not related to general pulmonary artery hypertension is or it is pulmonary artery hypertension, but it's not the kind that's usually responsive to nitrates, is COPD, any kind of obstructive process, because you're putting pressure on the pulmonary vasculature and causing the back pressure, volume overload. So if the patient has right ventricular failure, cor pulmonale, number one cause is left ventricular failure, but you also have, obstructive sleep apnea can cause this, then the patient needs to be diuresed. Now, what I also want to show you is the size of that right atrium. I mean, look at that. That is ginormous. This is also telling me that this is probably an acute on chronic process, because of the fact that this left atrium is just huge. So let's predict. What are we going to see from this patient? So you have a high pressure in the right ventricle. That's obvious by the D'ing of the left ventricle and of the septum. A very large right atrium. And so if we're thinking whole person approach, because as an osteopathic physician, we have to think whole person. In fact, all physicians should think whole person. But we should see jugular venous distension, lower extremity edema, more than likely pitting. You're probably going to see a cardiohepatic syndrome in which the liver is pretty much underwater. It is congested, so you're going to get transaminases that are elevated. You're going to potentially even get problems with coagulation, because your whole coagulation cascade, your factors are made in the liver. You can also get cardiorenal syndrome. Now the kidneys are going to be congested, and as a result, they're not going to function very well. You may go into renal failure. You can also get ileus. You can get an issue with digestion, and as a result, malnutrition, because visceral edema is real. And so if you see, third spacing, or you're seeing edema, and now you have a humongous right atrium like this, there's a possibility that you have bowel congestion. And there might be a lot of nausea. The patient won't tolerate eating, abdominal pain. So the question you have to ask yourself is, why is this happening? Now, when I teach my residents and my students, when you're seeing a patient, you always have to ask why. Why is this happening? You need 5 whys to come up with an answer. And you use your data, your labs and your radiology, your radiographic evidence tests in order to prove or disprove what you feel is going on. And so, this patient, I really don't remember. It was quite some time ago. I would have started to diurese right away. You have to get that pressure out. Or a CT angiogram, if it showed a pulmonary embolism, I'm calling the interventional cardiologist to do a thrombectomy. All right, so that's all for today. I want to thank you for your time, and looking forward to the next video. Have a good one.